I proceed to just to answer your query, sir. The idea came from what I normally do in my practice. It's just that more than the power, what I would be lamenting on is actually the finesse that you get from BSS. In fact, that was going to be my introductory statement before I could proceed with my presentation. We use viscoelastics in cataract surgery basically to achieve two purposes. One is the endothelial protection, and there's no substitute to that when it comes to protecting the endothelium mechanically by forming a layer over it, or under it to be more specific. And the other is space formations. For space formation in cataract surgery, we actually don't need the services of BSS, is what I came up with an idea. And then post-nucleus management in particular, where we actually don't need any endothelial protection, I use everything and I conduct all the steps under the cover of BSS, and I do not like to use BSS. And if you ask me why, then the answer is in the intracameral environment inside the eye, what circulates is the aqueous humor. And the BSS has got more chemical affinity to the aqueous humor than the visco has. So why should we use a foreign substance which is not really the eye's inherent constituent instead of something that we have available in our hands, which is much more mimicking the aqueous humor in its chemical composition. So let's go to certain videos. We all implant, most of us implant IOLs under BSS, but where we take a step back is actually the multi-piece IOL. The multi-piece IOL we normally tend to implant under the cover of viscoelastics. When multi-piece gets folded into the cartridge, it does so in two ways. One of the ways is the advancing haptic forms a sigmoid shape, a hyperbola kind of a shape. The other, when the haptic actually stands out, it stays straight because it's not a foldable thing in the multi-piece IOL. So I adopt different techniques to implant both of these IOLs under the cover of BSS. Let's look at the haptic being bent in a sigmoid fashion or in a parabolic shape. There, the cartridge is made very parallel to the eye. If you make it a little vertical or oblique, what tends to happen is the haptic gets kinked and there is a fold and acute angulation of the haptic which doesn't recover. So in the bag, it does not stay in the middle. The positioning inside the bag is not that good, and the overlap by the CCC is not that good. So if the cartridge is made very parallel to the eye, then it goes in smooth without bending it at any point. The second is this particular pattern of folding of the haptic where it stays stout and straight. Therein what you have to do is, and all the while the left hand has the 23 gauge cannula just flowing in BSS from here. Herein the haptic actually rotates 180 degrees. So you have to wait till the advancing haptic rotates. There it starts rotating and it occupies its position on the other side before you start rotating the rest of the IOL end. If you don't do that, then there's every possibility of the optic actually going very close to the endothelium and mechanically touching it, producing a destruction. So these are the two different ways of implanting a multipiece. There's no reason why we should shy away from it. CTR implantation. This was one of those cases wherein I was just doing the IA after nucleus management was complete, and I suddenly dragged the bag along with it. Look at that. It's dragged the bag. So I tried to inject some viscoelastic to free the capsular bag which was caught in the aspiration port, but I did it wrongly at the beginning. I pushed the viscoelastic from the same side from which the dialysis had happened. It was not helping me. So I switched hands, took the IA cannula in my left and proceeded from the other side and injected some dispersive viscoelastic to flatten the bag out and form the equator again, and it got released from the aspiration port. Very carefully, the rest of the cortex was washed using a bimanual IA, which is not my preferred modality of IA routinely, but in this case I had to switch over. But rest before implanting the IOL, there's no reason. We just need space formation here, and the bag has to be inflated, which the BSS is already doing. So we don't really need to be conservative in this and fill the bag again with viscoelastic. So with the same 23 gauge IA cannula, which is there in the left hand, the CTR injector goes in and starts injecting the CTR. The only thing we have to keep in mind here is the injection should not happen from the place where the dialysis has happened. You can see the eyelet rotating inside the bag beautifully at the equator, and then you take the IA cannula in the left hand and just nudge the trailing eyelet for it to occupy its position in the bag, and then the IOL can follow in to occupy its position which is designated. PPC and vitrectomy. This is one of those cases where I saw that there's a lot of asteroid hallosis in the vitreous space. So I decided to go in with the PPC, with the micro plexus forceps in the right hand, just the BSS cannula in the left. You don't need to inflate this eye with viscoelastic at all. There's a toric aisle which needs placement as well. And then I take this with the same swift motion, the right hand just switches the instrument, and then I go and do a deep vitrectomy to clear out all the asteroid hallosis from the vitreous cavity. Now, asteroid does not hugely cause a reduction in visual acuity, but it might just create that difference between a 6.6 and a 6.9. And there's no reason why I should leave my patient behind, because I'm implanting a toric and I'm promising him good vision, spectacle independent in the post-op period. Look at the red glow coming back to the eye when the asteroid hallosis are cleared. These vitruses are very fluid. So you can comfortably go deep, do a vitrectomy and clear out all the asteroid hallosis from the visual axis and leave the patient behind with a nice PPC sitting at the center with the toric aisle aligned. Explantation of pupil expanders. This is another area wherein BSS can help us. This is a Gupta's ring, an Indian-made counterpart of the Malugan, where it is dislodged. Of course, to implant this particular ring, you need a 2.8 millimeter section instead of a 2.2. But look at the way the IA cannula is supporting the ring. I'm not allowing the ring to get dislodged from the pupil, come up and then straightly hit the endothelium, because there is fluid circulating in the anterior chamber, so we have to be a little careful. But one by one, all these scrolls can be disengaged from the pupillary border, while the left hand is supporting the pupil expander from up above so that it doesn't pop up. The fluid current does not cause it to elevate and then hit the endothelium. Then one of the scrolls is aligned with the main wound, and you can just take a McPherson forceps. So unlike the Malugan, this doesn't have to go into an injector. So you can just pull it out. It's a 2.8 millimeter section any which way. So grab hold of one of the scrolls. Since most of these patients are toric aisles again, and I hate implanting toric aisles under BSS in particular, or even aligning them. So I exclusively use BSS for implanting torics, because the alignment always takes a hit if you use viscoelastic and give them a medium along which they rotate. However, if you're implanting a Malugan, like in this case, again a toric implant, there also the explantation can happen under cover of BSS, but the principle remains the same. Right now, because Malugan is a little difficult a ring, more than Gupta's at least, to disengage, because it is mechanical or dynamically a little different in shape. So right now the cannula is actually levitating it so that it lifts up, and then the hook goes in and captures one of the scrolls, the distal scroll, and then the cannula comes up to protect it, hitting the endothelium. The side scrolls have to be given a little bit of support with the second instrument, which I do now, again with the BSS cannula, no Sinskey hook is required. And then the distal scroll, while it dislodges from the optic, a counter traction has to be given, because it kinds of bites into the pupillary margin. So again, that can be done with the left-hand instrument, which is the IA cannula in this case. And lastly, there's a pediatric cataract wherein the IOL implantation is happening here as I have the BSS cannula in the left hand, and virtually everything, all the steps that follow this are done under BSS only. So starting with the IOL implantation, rotating and occupying its place, the vitrector comes in the second hand and then produces a PPC and a good anterior vitrectomy to remove the scaffold support for the lens epithelial cells to grow in the post-operative period. And then once it is done, while the BSS is filling up the anterior chamber, you can also take the bite under the cover of BSS. No need to put in an air bubble. You just can puncture the cornea and the sclera together while the BSS cannula is still in the right hand, and then you can just leave it. And we know that it's not exactly a tight suture, so you just make little taut so that the angle and the wound is supported tangentially. So that's about everything that's to be done on BSS, and I do under BSS. Thank you so much for the kind attention.
Thank you, Dr. Anurag. Actually, in your hand, all the procedure was going very smooth. But to a fresh person, I am little worried, because the 3-piece IOL, how we unfold in the posterior capsule, and CTR, the haptics, when you release it through BSS, it will be traveling so fast compared to Visco, no?
Well, it is not a bimanual injection. I think, that's probably the one subtle message that I would like to stoop and, submit with all honesty and a very soft baritone in my voice. I don't think it is actually that difficult. It's probably our mindset. We just don't want to accept that it is. We just want an extra sheet of coverage with the viscoelastic. Otherwise, BSS actually does a magnificent job in inflating the anterior chamber and gives us space to do everything. It doesn't travel fast if we do not push it fast. We just have to understand the mechanics. And I always trust the injector more than the manual method of implanting the CTR, because the injector is so well designed that you can actually dictate where it goes and where it rotates. For a dialysis which is more than what you saw in this case, maybe 4 to 6 clock hours, I might not do this. I might just be tempted to inject viscoelastic and then do, after supporting it with the capsular hooks. But for this many short, small dialysis, a BSS does a good enough job.
Yeah, Anurag, when you were showing us the 3-piece IOL going in, you can always rotate your thing
Pronate
and
your
see
hand.
that it goes like exactly inside instead of the tip showing up and down.
No,
That actually gave me a little bit goosebumps, like I was a bit terrified. Something might happen to the cornea and the PC.
if the advancing haptic goes into the bag, then you have no reason to have jitters, because then it will never hit the endothelium. If the advancing haptic goes into the bag, sometimes it unfolds in the anterior chamber, which you have to be careful about. So you need to have the rotation, the direction of the hand in such a manner that the haptic goes into the bag. Then you can dial in the rest of the IOL easily. But what you're saying is right. Pronating your hand is always an option. But with a proper loading and the optic remaining horizontal, most of the time it is not needed. It comes out in the horizontal plane.
Yeah, that's probably you're having one hand with the BSS and then it's a bit difficult. Maybe. It's a good surgery. Thank you.
Thank you.
Thank you.